Okay, good evening. My name is Hans Schneider, and I'm a chemical pathologist and endocrinologist from Melbourne, Australia. I'm going to talk about parathyroid hormone, the measurement and the role in the management of hyperparathyroidism and metabolic bone disease. Thank you for attending tonight's webinar. Parathyroid hormone is an 84 amino acid peptide, and I see my screen is not moving. There might be just some delay. So parathyroid hormone is an 84 amino acid peptide. The first 34 amino acids hold the biological activity, and it is made by the parathyroid cells that are in 4 little parathyroid glands at the corners of the thyroid. Sometimes there's an extra 5th gland present. This 84 amino acid peptide is secreted from these parathyroid cells in response to changes in the ionized calcium levels. The ionized calcium levels are recognized by calcium sensing receptors, here shown on the right, and the calcium sensing receptor signals for this release of the parathyroid hormone. The parathyroid hormone acts on specific PTH receptors in bone, where it increases bone resorption in the acute phase, and it acts on the kidney, where it increases calcium reabsorption and increases phosphate excretion. It also increases 125 vitamin D production, which then leads to increased calcium absorption from the gut, and it affects the FGF23 expression, and FGF23 is made by bone cells and impacts on phosphate excretion. This PTH has a very rapid half-life. The intact PTH has a half-life of minutes, and the fragments might circulate longer. The next slide shows you the different generations of PTH assays. You've got originally the first generation assays, which were using polyclonal antibodies in a radioimmunoassay, either N or mid-terminal. Today's labs use second generation or third generation PTH assays. The second generation assays are immunometric assays, so they have a capture antibody, most commonly a mid or C-terminal PTH antibody, and a detection antibody more towards the N-terminal end. And the third generation assays are differentiated from the second generation assays by having a very far N-terminal antibody that detects the first 4 to 6 amino acids. The next slide shows you the variability in patients, and you see in an individual patient as published now 10 years ago, you have this marked difference depending on which assay you use, up to 3.5-fold difference. And the next slide shows you in more recent, and the next one again shows you the variation in median results. So the median results, as you can see here, reach for this assay, for this quality control sample, from about 60 to about 95. And if you look at the result of the graph, the next slide, you see the wide variation of linearity of different assays. In blue here is our lab's assay that uses a third generation assay that typically measures lower than the second generation assays. The next slide, please. and that is due to PTH fragments. So the C-terminal fragments of PTH are generated in the liver and cleared by the kidney, but they can also be directly released by the parathyroid gland. They have a longer half-life than PTH and are increased in patients with renal failure. A particular one that had a lot of interest is one that was identified by HPLC and interfered with the intact PTH assays. And this fragment co-eluted with the 7 to 84 PTH fragment that was synthesized. And 7 to 84 actually acts as an antagonist on the PTH receptor, so had a lot of interest. And clearly these fragments interfere with the accurate determination of bioactive PTH. What about mass spectrometry? And in the next slide, there are three methods that show you the mass spectrometry. Zhang published in 2010 a MALDI-TOF mass spectrometry method, and they measured PTH after immunocapture with a C-terminal antibody, and they used a fragment to identify that. And you see there are a small number of patients and a number of fragments were detected. Lopez used trypsin digestion, again a C-terminal immunocapture, and now the patients are 24 and they find more fragments. Most recently, and I'll talk about that a little bit more in the next slide, is an essay by Crit Metapack. And sorry, can you just go one slide back? And they use 220 patients with significant renal failure and find 8 PTH fragments that are actually measured in renal failure. The interesting thing is that these mass spectrometric assays could not identify this PTH 7 to 84. All three groups were either not reporting it or not detecting it in measurable amounts. The next slide shows a review by Smith that summarizes the different fragments that have been identified, and you see here the 7 to 84 fragment was identified by HPLC only, while a number of more C-terminal fragments were identified by mass spectrometry. However, importantly, at the bottom you see also other modifications. The modified PTH 12 to 18 at the bottom is probably a phosphorylated PTH that is called amino-terminal PTH that has high biological activity and is found in some parathyroid adenomatous in particular. The other interesting one is one that is oxidized at serines 8 and 18. And this oxidized PTH has been identified by mass spectrometry in PTH preparations and loses bioactivity. Hocher et al., and that's the text on the right if you go forward, have identified and used assays, the next one and the next one, and they've used this oxidized PTH by removing it with an affinity column where they had a monoclonal antibody against OX-PTH, and then they measured PTH on the flow-through and correlated that against a number of outcomes, mortality in patients on hemodialysis and graft loss after renal transplantation. And there's a number of publications that are cited there. So the next slide, please. Shows the paper of Crit Metapack and from the Mayo group. What they have done is really quite nice. They have used both C-terminal immunocapture and N-terminal immunocapture to try to enrich this PTH before mass spectrometry. And they show with their method that they identify 1 to 84 to a very similar extent with both immunocaptures, which is a very good basic confident-inducing method to say we actually find this 184. The next slide shows you the separation of the different fragments, and they have isotopes of these fragments that they have used to identify and quantify the particular fragment. So these were very clearly identified, and subsequently the next slide shows you the measurement in a large number of patients with renal failure, 220 patients with renal failure, and you see that here shown as the log PTH, that the concentration markedly increases with very low poor renal function. The next slide shows you that they did not detect 7 to 84 or the oxidized form in their renal failure patients. Now, PTH is obviously very important in hyperparathyroidism because the diagnosis of hyperparathyroidism is the characterization of elevated serum calcium levels with normal PTH or elevated. The normal PTH would be inappropriate for the elevation of the serum calcium. And here is just some papers. These two papers are the Australian consensus guidelines and position statements of the Endocrine Society, the Australian New Zealand Endocrine Surgeons, and the Australian New Zealand Bone and Mineral Society that are in press in clinical endocrinology at the moment. And there's a lovely review by Walker and Shane about hypercalcemia that just came out last month in JAMA. Next slide, please. If we look at the causes of hypercalcemia, really, there are very big groups. The first group is the parathyroid hormone mediated, and the large majority of those are primary hyperparathyroidism, usually sporadic, but they can also familial and inherited forms be present. They can be as multiple endocrine neoplasia. They can be as familial isolated hyperparathyroidism or the hyperparathyroidism jaw tumor syndrome. There is very rarely a parathyroid cancer, and I'll talk a little bit later about tertiary hyperparathyroidism. The other big group, and these two groups, parathyroid hormone mediated and non-parathyroid hormone mediated, make up about 90% of hypercalcemias, are mainly due to malignancies. And in malignancy, the most important protein is the parathyroid hormone related protein that shares some N-terminal similarity with PTH and acts on the PTH receptor. There are sometimes other mechanisms present in osteolytic metastasis or in myeloma, and the other groups are much rarer. So granulomatous disorders can make 125 vitamin D. Obviously, a number of drugs can elevate calcium. Rarely you can have milk alkali syndrome where you have excess calcium carbonate with renal failure and you can't get rid of the calcium, and immobilization hypercalcemia is well described, as well as a number of others. Next slide, please. The primary hyperparathyroidism is probably the most common cause of hypercalcemia in the community. Incidence peaks in the 7th decade. Women have it more than men, and the large majority have single adenoma, but foregland hyperplasia is present in 10 to 15%. And we talked about the hereditary syndromes, and I will talk later on about familial hypocalciuric hypercalcemia, as PTH will help you differentiate from the primary hyperparathyroidism in that setting. But PTH is probably not the most helpful test there. Lithium therapy is associated with a greater prevalence of primary hyperparathyroidism, and at the bottom again the consensus statement of the Australians that are in press at the moment. Next slide, please. These shows in the next slide some results that show you the importance of could I have the next slide? The importance of different assays, and these are some experiences from the Alfred in Melbourne. We changed our assay here on the left bottom. You see the graphs in 2011 from one assay to another and changed back in 2014. And you see our numbers of patients with the ICD code hyperparathyroidism of inpatients markedly increased in that time frame. We then audited, with the help of endocrinologists, 320 patients, and we found that with one assay, I call it the A assay, we had 8 patients per month, and with the R assay, we had 6.6 patients per month. And when we looked at the quality of the diagnosis, here shown in green, we found that the quality of confirmed hyperparathyroidism, that means this is hyperparathyroidism where all the biochemistry fits, where the patients have a surgery and the hypercalcemia resolves, dark green, and then light green is the situation where you have all the biochemical features, but the patient doesn't have a operation, is markedly higher in the group 14 and 15. And these are 2 intact PTH assays, emphasizing the importance of your assay choice and the importance of your reference ranges. The next slide, please. The situation has been more complicated by the recognition that there is also another form of primary hyperparathyroidism that is normocalcemic, and here in red. So normocalcemic primary hyperparathyroidism is a variant of the more common primary hyperparathyroidism with hypercalcemia. And in the next slide, I show you some of the complications they frequently present in osteoporosis clinics, where they present with fractures, and they might have nephrolithiasis with renal stones. It's characterized by persistently elevated PTH levels, but they have normal calcium, and it's very important in these patients to measure the ionized serum calcium, because there is a subgroup of patients that are actually hypercalcemic and are not recognized. You obviously need to correct all other issues. You might have to correct their vitamin D, to give them vitamin D to normalize the vitamin D that might lower the PTH, and you might have to cease certain medications, but they do exist. A small subgroup of them then subsequently actually develop hypercalcemia. Next slide, please. This is to discuss the familial hypocalciuric hypercalcemia. And what this is a mutation in the calcium sensing receptor. What you see in this slide is when you increase your calcium, you lower your PTH release from parathyroids. And when you shift this curve to the right, you have a less sensitive calcium sensing receptor. This inactivating mutation has been well described. There's many mutations that have been sequenced and shown. Reversibly, you can also have more sensitive. Then you have what is called autosomal dominant hypocalcemia of infancy. Now, these patients have mild elevation of calcium, and typically they do not need intervention. You can differentiate them from primary hyperparathyroidism not with the PTH level, because the PTH level can be normal or mildly elevated. But when you look at the urine calcium is typically very low. So they have a low urine calcium over creatinine ratio. The next slide, please. Secondary hyperparathyroidism, and this is well recognized that as vitamin D levels fall, the PTH increases. And when we looked, and if you forward this 2 or 3 times, when we looked in 2004, we found there's seasonal variation in Australia like in other countries. Only in Australia in July and August it is winter. And in winter, you have lower vitamin D levels, you have higher PTH levels, and you have CTX levels or bone resorption markers that are also mildly increased. And Julie Pascoe basically did a sinus curve that shows the periodicity of the UV light and the falling vitamin D level. And as vitamin D drops, PTH increases, CTX follows, and fractures of wrist and hips increase as well. And some of that increase might be due to this variability. Next slide, please. Shows you the effect of correcting vitamin D in 2 patients. On the left side, you see you increase the vitamin D markedly and the PTH goes down into the normal range, while the calcium does not change, pretty close to the upper limit of normal. While on the right side, you also increase your PTH, you increase your vitamin D, the PTH drops, but the calcium remains markedly elevated in this patient with marked primary hyperparathyroidism. The next slide talks a little bit about renal bone disease. So chronic kidney disease, metabolic bone disease was mentioned by Sam before. PTH is an important and was the first biomarker that was used for the diagnosis and monitoring. We find secondary hyperparathyroidism early in the course, so 12% of patients with a GFR of over 80 already have elevated PTH. 60% of patients with a GFR less than 60 have elevated PTH. And PTH is stimulated by a variety of different mechanisms. So it's the decreased ionized calcium. The kidney makes less 125 vitamin D. There's probably as the very first marker an increase in the FGF23. There's phosphate retention, probably fairly late in the piece of renal failure. And we find that there is reduced expression of vitamin D receptors, calcium sensing receptors, FGF receptors, and clotho in the parathyroid glands. And in this setting, it is important that the Kidney Disease International, International Coalition for the Control of Kidney Disease and evidence-based recommendations recommends 2 to 9-fold increased PTH levels in end-stage renal disease. Next slide, please. This shows you adynamic bone disease and renal failure and osteoitis fibrosa. So the upper slide shows you in green calcified bone, and there is very little of this dark red material that is osteoid that is not yet calcified around it. So the black arrow shows that the osteoid is missing there. If you look in the lower picture, you see there is lots of this red stuff, and this is the white arrow that shows that around the calcified bone. So that's osteoid, and it shows you little bone formation. In addition, in osteoitis fibrosa, you also see marked increases in osteoclasts, here shown with the yellow arrow.
2 more minutes.
Bone disease, you have diagnosis that is important as the adynamic bone disease is much more likely with low PTH levels, and the bone-specific alkaline phosphatase contributes to that. In the contributors to adynamic bone disease, there are many to blame, but overzealous treatment of hyperparathyroidism, calcium mimetics, and bisphosphonates might contribute to that. And the next slide shows you tertiary hyperparathyroidism. That's where patients have end-stage renal failure, markedly elevated PTH, and have difficult to control hypercalcemia that might require parathyroidectomy. And we see that also even after patients have renal transplants, that they continue to have high PTH concentrations, so hypercalcemia. And I'm almost at the end. There's next slide shows secondary hyperparathyroidism after obesity. And these are 34 trials of 3,500 patients that show you that there's probably about a 40% frequency of hyperparathyroidism over surgery. The treatment has to be with calcium and vitamin D supplementation that needs to be individualized, with some patients still not controlled. So the last slide gives you the summary and some of the learnings. PTH measurement is crucial in the diagnosis of hyperparathyroidism and in chronic kidney disease, metabolic bone disease. We call them second and third generation PTH assays, not intact PTH assays, because they measure fragments. PTH fragments accumulate in renal failure. We've talked about normocalcemic hyperparathyroidism, FHH, and adynamic bone disease and osteoitis fibrosa, as well as after weight loss surgery. Thank you very much for your attention.
Thank you, Hans, for that very interesting talk.